Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being with us for our Community Lunch and Learn today, April 28th, 2017. A few quick preliminaries and then we'll get started with our presenter. If you are having trouble, you can email us at unccn@unc.edu. You can text or call us at 919-445-1000. We're going to use Poll Everywhere, and we'll talk about that in just a minute and how you can go ahead and answer our icebreaker question and then also our Q&A later on in the presentation. Check us out on the web at unccn.org, Facebook, Twitter, and YouTube. Lots of places you can find us. This is the Poll Everywhere question. Our first question is, cancer is defined as an uncontrolled growth and spread of abnormal cells. Now, you can pick A for true or B for false. And the way you tell us about your answer is you can either go to pollev.com/UNCCN, or from any phone that has a texting ability, one time you text the letters UNCCN to the number 22333. So you go 22333, then you'll go ahead and send the letters UNCCN. Once you do that, it will join you to our Poll Everywhere poll, and then you can answer A for true, B for false, whatever you think the answer to this question is. And then we hope that you'll be thinking about questions for our presenter throughout the presentation and then sharing those questions with us at the end of the presentation. So please keep track of those. We'll look forward to lots of questions at the end. All right. We have with us today James Evans, MD, PhD, and Dr. James Evans is the Bryson Distinguished Professor of Genetics and Medicine at the University of North Carolina at Chapel Hill. He directs adult and cancer genetics services and is clinically active in both medical genetics and general medicine. He is editor-in-chief of Genetics in Medicine, the official journal of the American College of Genetics and Genomics. Dr. Evans' research interests focus primarily on the applications of next-generation genomic analytic technologies in medicine and broad issues on how genetic information is used and perceived. He has been extensively involved in policy issues both nationally and internationally. He has been an advisor to the U.S. Secretary of Health and Human Services on the subject of genetics, health, and society from 2004 to 2010, and has been actively involved both nationally and around the world in the education of high court judges about genetics and scientific matters in general. All right. Well, Dr. Evans, welcome. We're glad to have you here today.
Nice to be here.
So, a lot of genetics in that introduction.
Yeah.
Tell us what led you to a career in genetics. How did that happen?
I've always been interested in kind of root causes for things.
Mm-hmm.
And when you start to study biology and get interested in biology as a kid, you quickly realize that at the very root of biology is genetics, right? It kind of is our code, and it runs much of what we do. And then when I became interested in medicine, it took me a while, but I realized I could combine my love of genetics with my love of clinical medicine.
Great.
So it's been a fun course.
Great. Well, we are so glad to have you here today. Let's take a look at that poll, see what we've got. We're running strongly on the true. What do you think? Are they on the right track?
They don't need this lecture.
Okay, we're good.
Yeah.
All right, but we hope you'll stay anyway. So with that, cancer, the role of family history and genomics. We're so glad to have you on board.
All right. Well, thank you. I'm in honor of everybody's giving up their lunchtime for this and staying inside a room and watching a video. I wore one of my nerd science ties, so you can see the DNA double helix on that. So I wanted to talk to you very broadly about cancer and about cancer genetics. And I wanted to start really way back because I think it's useful to think about cancer in its historical context, and cancer is indeed an ancient disease. The oldest known reference we have to cancer is in a papyrus manuscript from ancient Egypt, and what we have possession of is a papyrus that is about 2,500, about 3,500 years old, but it probably was a copy from a text that was much older than that, about 5,000 years ago. In this text, it's remarkable. It discusses treatment and recommendations for surgery, which remains the mainstay when it can be employed for the treatment of cancer all these millennia since. It also discussed some rather primitive chemotherapeutic attempts with pig's ear and barley, and hopefully we've come a little ways since then. And as far as knowledge of cancer, that papyrus is oldest, but there are examples of actual cancer found in Bronze Age skeletons, in Peruvian mummies, for example, and even in fossils of our evolutionary predecessors. Before there were even humans, there was cancer. In China, there was a collection of writings about 500 to 300 BC that contained really one of the first clinical descriptions of breast cancer, referred to metastasis and referred to the prognosis. And Hippocrates was the one who actually coined the term cancer. And it's from the Greek karkinos, which was due to the infiltrating nature of the tumors. And you can really see that here with the tumor kind of infiltrating through this lung, otherwise normal lung tissue. And that's where the zodiac symbol of the crab became associated with cancer, because of those kind of tentacles and that infiltrating nature of cancer. So we've known about cancer for a long time. We've known about the problems it can cause for a long time. But we only in the last century or so have come to understand it better on a cellular, and only in the past few decades on a molecular basis. And cancer is, as you all know clearly, the uncontrolled growth and spread of abnormal cells. And they really show three characteristics that differentiate cancer from non-cancerous growth. So you can have a tumor, but it can be non-cancerous. All right? So all cancers, well, there's one exception, and that's the blood cancers, but cancers in general form tumors. They form masses of cells, and they can affect any cell line in the human body. The one exception I mentioned was that cancers involving blood cells oftentimes, for example, in the setting of leukemia, don't form a tumor per se. Those cells are free-floating. The second characteristic, though, that something has to have to be cancer is that the tumors have to be invasive. That is, there are tumors that just, they sit there and maybe don't grow, or they sit there and they kind of grow very slowly and kind of push bluntly out into the tissue around them. But that isn't cancer. It's cancer when that growth doesn't respect normal anatomic boundaries and invades vital structures. And then finally, the third characteristic of cancer that ultimately causes many of the clinical problems is that cancer is capable of spreading to distant sites. That is, in a non-contiguous fashion, in a non-connected fashion, the cancer can travel, like one cell can travel to another part of the body and set up shop there and cause a tumor there that then in turn can invade and it can in turn metastasize. So you can see it's a kind of amplifying type of process. And the metastasis, the spread of those cancer cells, can occur via a few different mechanisms. Those cells can spread via the bloodstream, they can spread via the lymphatic system, and they can spread through cavities in the body. The most salient example of that would be, for example, in the setting of ovarian cancer, where the cells will physically move through the abdomen and set up shop in other places in the abdomen. So our understanding of cancer, as I said, has gradually progressed over the last roughly century and over the last 20, 30 years very, very greatly. And what you have to remember about the human body in understanding cancer is that we consist of a lot of cells. Our body is made of cells. And indeed, our body is made of about 10 to the 14th, that is about 100 million cells. Really an astronomically large number that's virtually impossible to understand on any intuitive basis. It's hard to get one's head around the number of cells in the body. But those cells, or especially what are called stem cells in each of our tissue compartments, are constantly undergoing division as well as programmed cell death. So we start out with one cell, and the process of mitosis leads to two cells, and then those can divide and so on. And as you can imagine, cell division, that is mitosis, has to be precisely regulated, right? And cancer results when the regulation of this cell growth goes awry. So this really starts to get to what causes cancer on a molecular basis. Cancer is caused when we have mutations in growth-regulating genes. We have in our genome about 22,000 genes. It takes about 22,000 different genes to make a human, all right? And a few hundred of those genes encode proteins which regulate cell growth. So many of those 22,000 genes have nothing at all to do with cancer and nothing at all to do with cell growth. For example, we have pigment cells that produce pigment. And the genes that encode that pigment, say melanin, those genes really don't have anything to do with cell growth. It's the handful of cells in our genome that regulate that process of cell growth and cell differentiation that are the culprits in causing cancer when something goes wrong with them. And there are three main categories of genes that regulate cell growth. There are proto-oncogenes. These are genes that act normally to spur on the growth of cells, right? We need those because we're constantly losing cells. Think about it. We all started out as a microscopic one-cell organism, right? After fertilization. And somehow there had to be a lot of replication and cell division to produce your body consisting of about 10 to the 14th cells. And proto-oncogenes are the genes that make proteins that then spur on cell growth. So the second category, though, is that the body desperately needs. We don't just need genes that make things that spur on cell growth. We also need genes that put the brakes on cell growth, right? Because if all we did was divide our cells and reproduce our cells, obviously that wouldn't really be compatible with the finely regulated organism that the human being is. So tumor suppressor genes inhibit proteins which in turn, they encode proteins which inhibit cell growth. So that really, you can think of proto-oncogenes and tumor suppressor genes as the yin and yang of cell growth. They're doing the opposite of proto-oncogenes. And then finally, there are gatekeeper genes, and these genes encode proteins that maintain the integrity of our DNA. Because if we lose the integrity of our DNA, then we will get errors in these genes, and errors in these genes that will dysregulate cell growth, and you will end up with cancer. So those gatekeeper genes we think of as really proofreading and editing genes that keep our nice, DNA double helix intact and keep it from accruing mutations and changes. So it's mutations in growth regulatory genes, these three classifications that are the common denominator in providing an explanation for all cancer. And, I am old enough to remember when I was in medical school, when I started my first year in medical school, none of these genes had been described, and we didn't really understand cancer at a molecular level. So since the early 1980s, all of this has been discovered, and and we now understand quite a lot about mutations in growth regulatory genes. So let's talk for a minute about how cancer develops. The transformation of a cell from being normal to being cancerous is one of successive mutations in various growth regulatory genes. So it's not enough to just get a mutation in, say, a proto-oncogene. That doesn't turn a cell cancerous, nor does one mutation in a tumor suppressor gene. It's the collection of many mutations in such genes that leads a cell and its progeny to become overtly cancerous. So think for a minute about a little cluster of cells here on your skin. Just look at your own skin and try to use your eyes as a microscope and see this little cluster of cells. And pick out one of those cells. And just think about what happens when that one cell acquires a mutation in one of those types of growth-controlling genes. That cell now has a growth advantage. It isn't cancerous yet, because all it has is really one mutation that gives it a little bit of a nudge along the pro-growth side. But because it is now goosed, if you will, in its ability to divide, it now outstrips the surrounding cells and it makes copies of itself. Because that's what mitosis is, right? It's just making copy of a cell. So now you end up with a cluster of cells here that all contain that mutation that was originally accrued by that single cell. And now one of these cells, all right, say that one right there, develops another mutation in one of those growth control genes, a different growth controlling gene. Well, it now has more of a growth advantage and it leads to more cellular division and so on. And eventually, with enough rounds of this, a tumor develops. And you can see there a skin cancer. So the question of what causes cancer, well, this is just a joke slide to interject that our, we hear a lot about what causes cancer, what causes heart disease, and sometimes one gets the impression that it's just a random process, right, where you spin the dial, coffee can cause depression in twins, right? But asking what causes cancer is really the same as asking how do we acquire mutations in growth regulatory genes, right? Those are the same question, and we now understand that over the course of the last few decades. Well, the most important reason why humans develop cancer, believe it or not, is chance. Okay? Again, we consist of 100 million cells. The chance that one of your cells will acquire the types of mutations in its progeny, the types of mutations that then lead to cancer in the course of your lifetime, begins to be pretty high by the time we get old enough. In fact, by the time you and I are 80 years of age, there's a 40 to 50% chance that we will be diagnosed with cancer. So chance is an absolutely critical reason why cancer occurs. It occurs, and it explains why cancer is usually, though not always, a disease of the elderly. The second reason that we acquire mutations that lead to cancer is, and I would just add, going back to chance here, remember, we are exposed inevitably on a daily basis to things that can damage DNA. Right now, you and I are being bombarded by cosmic rays, for example, that can damage DNA. The normal metabolic processes that go on in our body can damage DNA. So again, these chance occurrences are something that we can't really get away from. Now, exposure to DNA-damaging agents is another reason that we can sustain damage to our DNA and, in turn, mutations in those specific growth-controlling cells, growth-controlling genes. And carcinogens are simply agents that can damage DNA and lead to cancer. And a really good example of that would be UV light and skin cancer. So this is why individuals who frequent tanning booths, all right, are at a much higher risk for skin cancer. It's why individuals who live in Australia have a much higher chance of skin cancer than an individual who's raised in, say, Vancouver, British Columbia. So some of these agents that damage DNA and in turn cause mutations in growth-controlling genes and hence cancer are things that are avoidable. And tobacco is the classic example of that. Tobacco smoke contains many carcinogens, and it leads to damage to the DNA in our bronchial epithelial cells. and in turn cancer. You hear about radon, and the list goes on. And finally, really getting to the crux of today's talk, heredity, right? So sometimes a person is born with an error in one of those growth controlling genes, and that puts their cells, all of their cells, at a little bit advanced stage along that continuum that can lead to cancer. So that's really what I want to talk about in the rest of the talk. And examples of these that you probably have heard of include, for example, the BRCA1 and BRCA2 gene. Many of you probably read Angelina Jolie's op-eds in the New York Times a few years ago, in which she discussed being diagnosed with a mutation in her BRCA1 gene. So there are signs that we look for when we take a family history to try to ascertain whether an individual might be at increased risk for cancer because of hereditary aspects. So one of the things you would look for in a family would be many affected individuals. But remember that cancer is unfortunately a pretty common disorder. So when you take a family history on people, you're going to find some cancer. It's quite rare to take an extensive family history on somebody and not find any cancer at all. You also have to consider the denominator. And what I mean by that is, if you forget about these people, you'd say that, well, she had cancer, he had cancer, and these individuals had cancer, and gosh, that's really impressive. And while this is still an impressive pedigree, right, there's a lot of cancer here, you can also see there are a lot of people who didn't get cancer, right, and it's important to take that into account. The age of diagnosis is important. As I said, we can readily understand now why cancer is predominantly a disease of the elderly. But when we see cancer at a young age, it makes us wonder, gosh, say this is breast cancer. The occurrence of breast cancer in the 30s or the 20s is very unusual. And when you see it, you start to wonder, gosh, is this something where there was a hereditary predisposition? Multiple primaries, so breast cancer in both breasts, or colon cancer occurring in 2 or 3 parts of the colon at the same time. And then, for reasons that aren't as intuitive, and frankly that we don't understand well, certain combinations of cancer types in a given family is a good hint towards the possibility that there's an underlying genetic predisposition. And those cancer types are, for example, when you see breast and ovarian in a family, or you see colon cancer and uterine cancer in a family, in the same family, that begins to give you clues that you might be dealing with a hereditary predisposition. Unusual presentations, like we see here, that is, for example, breast cancer in a male, should really make you think strongly about the possibility of an underlying genetic syndrome. And then certain rare tumor types. For example, adrenal cortical cell cancer is a very rare tumor. When you see it, you should really be thinking about the possibility that this is caused by an underlying genetic mutation in that individual. And then certain ancestries have an increased risk of carrying such mutations. And for our purposes, the most important population, just because of sheer numbers, would be individuals of Ashkenazi Jewish descent. Such individuals carry a significantly increased risk of harboring mutations in specific cancer genes, such as BRCA1 or BRCA2. Really, any population that has been reproductively isolated, either through cultural reasons or for geographic reasons, can show such differences in the frequency of having mutations in a given gene. And genetic testing can provide important information to families. Here are a few clinically prominent family cancer syndromes. And I put this asterisk here, remembering when I say clinically prominent, I don't mean that these are really common in the general population. They're common to me because this is what I see and it's what is referred to me. But about 5% of cancers in the general population occur because of an underlying genetic predisposition. So that should kind of put it in perspective that most people who get cancer don't get it because of heredity. But it's very important to keep it in mind and identify those individuals who actually have cancer because of a genetic predisposition. And these can be due to genes such as BRCA1 and 2, a gene called P53 you might have heard of. Lynch syndrome is a syndrome that causes a very high risk of colorectal cancer, as well as in women endometrial cancer and some other cancers such as ovarian and others. Polyposis syndromes, in which people have many, many polyps, not the 2 or 3 polyps that you might get on a screening colonoscopy normally, but that is dozens to hundreds to even thousands of polyps that are then at much, much higher risk of developing into cancer. A syndrome called Li-Fraumeni syndrome that predisposes to many different types of cancer and so on. And I would just say that hopefully you guys have I'm not sure how to go back, or maybe I can do this. There we go. This is an excellent resource for those of you who want to look into the different cancer predisposition syndromes and genes. It's genereviews.org. So let's concentrate on probably the most famous of the cancer genetic syndromes that is caused by, for example, BRCA1 or BRCA2. In this case, I show you the cancer risks for a woman who has a mutation in the BRCA1 gene. Her lifetime risk of breast cancer is up to 85%. And there's a window there. There's a 50 to 85% would really be the right window. And her 10-year risk of a second breast cancer is about 35%. So that's quite significant, right? It's much higher than a woman who develops breast cancer not in the context of an underlying predisposition. And she has to think about that as she thinks about her treatment options. Her lifetime risk for ovarian cancer is about 50%, and that's a very serious issue because while we are pretty good at treating breast cancer, we are not good at all at treating ovarian cancer. So there are a lot of decisions that these high-risk families like I've described have to make. One of the decisions can be, well, I'm going to undergo increased surveillance to try to pick something up early if it occurs. And what we know is that mammography in this context is not very good. Right? You cannot just rely on mammography. We know that MRI is actually pretty good. So one does stand a pretty good chance of picking up cancers in a woman with a BRCA1 or a BRCA2 mutation by doing routine annual MRIs in addition to mammography. You should remember, of course, that screening modalities are not preventive, right? They hope to pick something up early. That's not a nonsensical hope. It's a good hope, but nevertheless, it doesn't always work. Ovarian cancer in the setting of screening is particularly problematic because we have no good screening modalities for ovarian cancer. And I would emphasize to you that while CA125 levels and transvaginal ultrasounds are often done in this context, there really isn't a bit of evidence to suggest that they are effective in saving lives or extending the life of individuals. And in high-risk families, one can also contemplate risk-reducing surgery. So risk-reducing mastectomies, removal of both breasts, does indeed, as you can imagine, greatly reduce the risk of breast cancer by over tenfold. And I say it's not eliminated, that's technically true, but if done in the hands of an oncologic surgeon who's used to doing these kinds of surgeries and removing the at-risk tissue, it is highly, highly effective. For the ovary risk, really surgery is the only option, and we recommend removal of the ovaries in a woman with BRCA1 or BRCA2, for example, once she has completed her reproduction. And that greatly reduces the risk of ovarian cancer, but doesn't reduce it completely because of cells that are left behind during embryogenesis in the abdomen and pelvis that aren't contained in the ovaries. Interestingly, if one pursues risk-reducing oophorectomy, removal of the ovaries, before the age of 50, it also reduces the risk of breast cancer because you have subjected the breast then to less estrogen stimulation. So, why look for a genetic explanation for cancer? Why engage in things like genetic testing and family histories? Well, it's because it can do three things. It can guide management at diagnosis. For example, a woman who's diagnosed at 40 years of age with breast cancer, who's found to have an underlying mutation, may well say, you know, I'm at a really high risk of breast cancer going forward in the remaining breast tissue if I have just a lumpectomy, that is removal of the tumor, breast-conserving therapy, and I'm at increased risk in the other breast, of course, so I'm going to have a risk-reducing bilateral mastectomy. So many women, but certainly not all, choose that option, and knowing that she harbors a mutation that puts her at high risk is, of course, indispensable information in making that decision. It also guides management after treatment and in the unaffected patient. That is, a woman who carries a BRCA1 mutation who's decided, for example, to have breast-conserving therapy may well and should elect to have MRIs, right, each year. It will affect her management down the road. And she should choose to have risk-reducing bilateral salpingo-oophorectomies, that is, removal of the ovaries. It also greatly guides decisions of family members, right? The family members can now avail themselves, if a mutation is found, of deciding, okay, am I at risk or am I not at risk, and do I need to have enhanced surveillance? Should I consider risk-reducing surgeries, etc.? And then finally, I wouldn't minimize or completely neglect the benefits of providing an explanation to somebody. I can't tell you how often a woman will say to me, you know, why did I get cancer? And even when there isn't something specific we can do, for example, we are unable at present to fix that gene through things like gene therapy, which remain an aspiration and a hope. You know, making sense out of our world is something that most people value, and they value simply an explanation. And then finally, to some extent, it can guide chemotherapeutic decisions as well. We're now entering an era in which certain chemotherapeutic agents are known to be more effective in the setting of an underlying BRCA mutation, for example. So this really brings us to this issue of predictive genetic testing, and it consists of testing for genetic alterations, these mutations that predispose an individual to developing a specific disease at some future time. There are uncertainties associated with it. For example, the timeline is long. If I tell a 20-year-old woman that she has a BRCA1 mutation, I can tell her the chance that she will develop cancer, say to the age of 80, but I cannot tell her when she will get cancer, and some women with such a mutation will never develop cancer, although that's the minority. And the predictive power in general of genetic tests ranges from very low to very high. And I would emphasize that the kinds of tests that are done responsibly in a medical context are typically tests for those mutations that confer a very high predictive power. It doesn't do us or the patient much good to say that you have a very, very small increased risk of this cancer or that cancer. On the other hand, if we can say with some certainty that this confers a high risk of a cancer, then that leads us to tangible things we can do to prevent it. And we now exist in a changing landscape where we're able to analyze our genomes and our genes with unprecedented abilities. For the past 20 to 30 years, we've been able to do single gene testing. That is, I can test your BRCA1 or your BRCA2 gene. We now, however, can look at panels of genes. I can look at 5, 10, 20, 50 genes that all might be relevant to a patient's presentation. And we can even sequence all your genes. Usually, in clinical context, that isn't something that really makes any sense. But we have the technology now to look at the genome in really unprecedented ways. The difference in whole genome and whole exome sequencing is whole genome sequencing looks at all of your 3 billion nucleotides that make up your genome. But the fact is that most of those nucleotides we don't know how to interpret. Most of them aren't really doing anything. So whole exome sequencing is really looking at all of your genes, all of your, for example, about 22,000 genes. And these choices now exist because of a technology called massively parallel sequencing. This is a picture of 1/1,000,000th of your genome. And if we were to sit here and I were to show a slide like this every second, okay, we would still be here in 12 and a half days, and I would have only gotten through the half of the genome that your mom gave or the half that your dad gave. The genome is unimaginably large. It is interspersed with genes, and you differ about every 1,000 nucleotides, that is about every 1,000 bases or rungs on this DNA ladder. You differ from the person sitting next to you, where you might have a C and they might have a G. You might have an A and they might have a T. Many of those are meaningless, have nothing to do with you or your health. Some of those influence traits. It's why some of us have blue eyes and some of us have brown eyes. And some of those polymorphisms, those changes, influence medically important characteristics. And then occasionally somebody has an overt mutation, not just a polymorphism, but a change in their genome that really greatly influences our health. And we now can sequence DNA very, very quickly, and this is due to miniaturization and multitasking. There have been, for decades, we've had a variety of chemical reactions that we can do to sequence DNA. The problem has been that we had to do that one tiny fragment of DNA at a time in a test tube that you hold. Now, however, we use chips that have on a chip the size of a quarter, millions of tiny little test tubes, if you will. And by diluting, fragmenting and diluting DNA, putting them into these wells and carrying out these same reactions that are decades old, and applying miniaturization and then informatics processing, we can query each of these wells with a laser, and we can assemble entire genomes and sequence many, many genes at the same time. And this is an example of the cost of gene sequencing. It's plummeted over the course of the last 2 or 3 decades. And the only thing that I can really think of that parallels that reduction in cost and that increase in our abilities is something like computers and consumer electronics. Very few of you are either old enough or nerdish enough to remember this, but I remember it because I'm both. This is the Commodore PET 2000. It was the very first personal computer, and it cost over $3,000 in today's dollars, and yet it contained about 8 million times less memory than the smartphone that you probably have in your pocket or your purse. So because of this technology, we can now do what are called gene panels. We can test patients for mutations in a variety of genes that predispose to cancer. And this was very difficult for a non-technical reason, a legal reason, up until June 13th of 2013. But that's when the Supreme Court of the United States ruled unanimously that patenting genes isn't allowable, isn't legal. And on that very afternoon, many different laboratories then began to offer the sequencing of genes on a clinical basis, and the cost has declined and the quality has gone up because of this freeing up of the market. And now I very routinely get a 6-gene, sometimes a 17-gene panel, rarely a 43-gene panel. You can see the prices there, but I would tell you that insurance, when this is indicated, largely pays for this. Medicare pays for it in the right circumstances. So these have become affordable, and actually these prices are a little out of date. They are now lower. But with more confusion, or with more information, comes more confusion, right? Some of these gene panels contain genes we really actually don't know a tremendous about, and it can be challenging for experts as well as more general practice people to really make sense out of this. And the problem is when you do gene panels, you also find things you don't quite understand as well. So I would urge you, if you are contemplating genetic testing or contemplating it for a patient of yours, that it probably makes sense, for example, to talk with a genetic counselor or a medical geneticist, though there are far more genetic counselors than there are people like me who have, as physicians, who have specialized in this. I would tell you that it's always important to test an affected member when possible. So this may be the person coming to you for advice, but what you would tell her is that it's a lot better to test your sister or your mom or your brother because it will aid us in the interpretation of results. It will aid us in figuring out what is a true positive and what's a true negative. That will aid us in what I alluded to before, these variants of uncertain significance that we very commonly now come across as we sequence people's genes. And as I mentioned, this issue of true negative versus false negative, if this is a woman who's diagnosed with breast cancer at 45, I very well may sequence some of her genes. And if I don't find a mutation, I'm pretty reassured. But think about this woman with breast cancer, and I sequence her and I don't find an answer. I'm not as sanguine about that, right? Because her brother got breast cancer, her mom and her aunt and her grandma got breast cancer. In that case, when I get a negative result on sequencing her genes, I'm thinking that's a false negative and there's something we don't understand. Deciding what test to pursue is hard. That 43-gene panel is not necessarily better than the 6-gene panel. More is not always better, and again, this is where I'd put in a plug for talking to geneticists like me or a genetic counselor, of whom there are many more than folks like me. So I want to finish up with just a couple of slides because I frequently get asked about, well, what about direct-to-consumer genetic offerings? Most of you have heard ads on the radio or seen them on TV. And really, I would tell you that there's a real range. Some of those are utter nonsense, like, you'll see advertisements for dating genomics. Send us your sample and we'll match you up with people who you'll, be a good match for in the dating community, and that's obviously ridiculous. Same with nutrigenomics. We don't know enough about genomics and nutrition to look at your DNA and say you should eat this or you should eat that. I can tell you what you should eat. You should eat a diet rich in fruits and vegetables and low in animal products. I mean, that's, unfortunately the reality. We need a genome to know that. There are genes that are associated marginally with better athletic performance, but the companies that offer to tell you what sport you should push your child into are selling snake oil. And finally, there are a lot of medical offerings, and most of those are snake oil as well. And I'll have one more slide on that. But ancestry testing is actually fine in the sense of accuracy. You can send your DNA sample into a variety of different companies, Ancestry.com. I don't have any connection with any of these companies, and they will tell you in with reasonable accuracy in a broad sense where your ancestors came from. The thing I would urge you to remember is we all came from Africa a short 60,000 years ago. So whether my ancestors took a left turn coming out of Africa and somebody else's took a right turn, I'm not sure how really meaningful that is. I want to end with just another note about the kind of medical offerings. They've been in the news lately because just a week or two ago, one of the companies, 23andMe, was cleared by the FDA to offer a fairly random set of 10 genetic tests. I would caution you about those. These companies have a really remarkably consistent record of poor performance. I could go over paper after paper that basically shows that if you send the same sample to these different companies, you get vastly different interpretations about your risk of disease, and that has been replicated in the now very modern era with people sending the same genomic sequence to different interpreters and getting vastly discordant results. And I would also add that the offerings by these companies are extremely incomplete and are definitely not a substitute for testing that's done in a thoughtful manner. I want to tell you one slide that I think is important because I've been talking about germline mutations. That is, mutations that we carry in all of our cells. There's a lot of excitement now about looking at the genomic sequence of tumors themselves, and it's legitimate excitement. For over a century, we've really approached cancer in the same way. We've looked at it under the microscope and we've said, oh, this is breast cancer and it behaves this way, and we should treat it in this way. Now that we're able to dissect the genome of tumors, we have the prospect of defining the specific mutations. Remember all those mutations I talked about at the start that develop and drive tumor growth. And eventually, I suspect, tumor classification and our treatments of tumor will rely a lot on the sequencing of tumors, and that's something that is increasingly being done, although it remains, by and large, a research endeavor. And I just want to end on a hopeful note. You know, cancer is a horrible disease, and we have all, whether we are in medicine or whether we are simply parts of families, we've seen cancer do awful things. But I just want to remind you that, you know, it in the end it's limited. It can't cripple love or hope or destroy peace or kill friendship or suppress memories or silence courage. So, you know, I think one of the real blessings of being a physician who sees cancer patients is that I am inspired on a daily basis by the ways, the heroic ways in which people cope. So I really didn't want to end on a bad or a negative note. So I will stop there and be happy to entertain any questions that anybody has.
All right. Dr. Evans, thank you so much.
You bet.
I want to remind our audience of how they can get those questions to us, and it's very easy. You just go to pollab.com/UNCCN, or you can go ahead and just text us those questions. If you already texted UNCCN once to the number 22333, you got a little join message and you're good to go. If you haven't done that, do that just one time and then go ahead and text us your questions. And here we go. You are phenomenal. All right, thank you so much. That's lunch and learn.
That's very kind of you. I appreciate it.
Let's see, I've got one while we're waiting for others to come in. So I'm imagining, you know, people getting genetic testing for a variety of reasons. There's a lot of data there that we don't know what to do with yet.
That's right.
Is that correct? And if so, how is that going to emerge as we get more and more information that we can correlate with that genetic information? And then how does somebody, you know, find out 6 months, 2 years, 5 years down the road that there's something that's relevant based on something we know in the future that we didn't know?
That's a great question. You know, we are in an unprecedented era of knowledge accumulation. And there are two sides of that. On one hand, it's very exciting, right? It's exciting for us as providers. It's exciting for patients. On the other hand, when you are in a field when it's burgeoning this rapidly, it means there's a lot we don't know, right? And we sequence people's genes, and you know, I tell the students, if you aren't comfortable being an idiot, right? If you aren't comfortable being proven wrong multiple times a day, don't go into medicine, and definitely don't go into genetics. And so to me, the corollary of that is we have to be humble, and we have to remember there's a lot we don't know, and we can't overinterpret findings. And I think that's a danger in this day and age when lots of people are getting their genome sequenced and all. I would just caution you that we still don't really know how to interpret a lot of things, so you have to be careful with it. What you brought up at the very end is important, and that is that we will know more as time goes on. At the end, so every patient we see, we write a letter to, because this is complicated, and I think they deserve a document that really explains to them what the heck we told them, because, you know, you can't expect people to remember everything you tell them. And at the end of every one of those letters, I say, please email me or call us. You know, it's free. Each year, maybe when you have your physical, something that spurs your memory, just to have us pull your file and see whether there have been any advances that affect you. We try to obviously maintain good records, and we try to contact people when there's been something that could affect them. But the fact is that 5 years hence, right, I might not remember you, right? And I might not remember the details of your case, but you're going to remember you, right? So all you have to do is jog my memory so that I can, okay, I'm going to pull your case and look. And then finally, I would just say that the participation by patients and providers in research endeavors is important, because it's the only way we're ever going to be able to really make sense out of all this information.
Okay, good. That's helpful. Again, please, if you have questions, get those to us either on the web, pollev.com/UNCCN, or using that texting method that we talked about. Let me drill down a little bit more.
Yeah.
So I have a favorite pair of shoes. Company hasn't made it for years and years. I put a search out on eBay, and once every 3 or 4 years, I get a little ping with an email that says, "Hey, Tim, that pair of shoes, somebody's selling it somewhere, your size." And I can go, great, and look at that. Is there any sort of similar database technology we would expect so that with my genetic makeup, all of a sudden, and my screening, I can all of a sudden get something in the future saying, hey, we just made a new discovery, and based on this, that, and the other, you should be concerned about this.
There are two things that come to mind. Okay. One is a colleague of mine that I work closely with, Jonathan Berg, runs an effort called ClinGen. It's an NIH-sponsored, basically giant database that is trying to hoover up all of these variants, all of these DNA changes that are seen in patients, being tested all over the world, so that along with information on them, so that anonymized information, so people's identity is protected, so that we can have a central clearinghouse and begin to make better sense. The other thing I'd mention is in the journal that I edit, we recently published an article by a group that really solved the genetic basis of a disease by using social media. And the parents of these children got together on Facebook, and then they got together with a couple of researchers, and it all led to solving this disease. So I think that our increasingly interconnected world will, if we use it right, foster our ability to make sense of these things.
Good. Yeah. So social media crowdsourcing.
Yeah, exactly.
Terrific. What's next? Obviously, you can't see into the future, but what are some of the things?
Well, I would say two things. One is that I often get the question of, we can literally hold a gene in our hand, and we can tweak it, and we can edit it, and I can give you a tube full of these genes that are, right. They have the right sequence. And yet here I am with a mutation that's causing me disability or illness. Why can't we just fix my genes, right? That's gene therapy. The notion has been around for decades. It's gradually gaining ground. So, what I hope is that someday we'll be able to do this. But what I want to emphasize there is that science is a slow process, and medicine's an even slower process. While we have to research these things and we have to explore these things, unfortunately, we also have to recognize that it's slow. And while we're researching the genetics and the causes of these things, the other thing to remember and to talk about your patients with and your family with is, there are a lot of things we can do to minimize our risk of cancer, right? And not smoking is probably the most important. So I may be a bit geneticist, but I still talk to my patients about not smoking and doing, eating right and exercise, because those are things that really are in our under our control to some extent, right? It's hard to live a healthy life. It's very hard, but at least we can make efforts along those lines, and those efforts will pay off.
Right.
So.
All right.
Well, thank you very much, everybody, for taking time out, especially on this nice day, and thanks for your attention.
All right. Thank you. Let me just remind our audience of a few things. We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obure, and Alan Brown for all of the hard work that they do to make this series and other series possible. Next Community Lunch and Learn will not be the fourth Friday, but will be the third Friday, May 19th, and that's Melanoma, Early Detection and Therapeutic Progress. Speakers David Olilla, MD, and Andrea Sacconi-Snyder, hairstylist. This should be a really interesting presentation, and we've got the added benefit. We don't typically have a continuing education component to our community lunch and learns, but for this particular one, the North Carolina Board of Cosmetic Art Examiners will they'll allow a 1-hour CE credit to be awarded through this presentation, and you can find out more about that unccn.org/melanoma. Again, find us on the web, unccn.org. Ask us questions. Look at our library. With this will make, I believe, 187 different lectures online.
Wow.
Lots of good material there. So we hope you'll visit us there. Let us know your thoughts, your suggestions. Hope that you have a great afternoon. Thank you so much for being with us today. We'll see you next time.
Bye. Thank you.